Sorry, the coffee breaks are so short, but there's obviously, as you know, quite a lot to pack in. So for the last session, we're going to talk about, and thank you very much, everybody, for staying. Good commitment. We're going to talk about the four big culprits, and we're going to talk about special circumstances, so obstetrics and paediatrics. And so we will start with the biggest of big culprits, antibiotics, and Shoaib Nasser from Adam Brooks will talk about this. Thank you very much, Shoaib.
Thanks. Okay, thanks very much, Tim. So I'm going to be talking about antibiotics, and I thought I'd go straight into the key findings. So you've already heard that antibiotics are the most common cause of perioperative anaphylaxis, and these comprise 35% of all cases. Previously, we used to think that, well, in fact, neuromuscular blocking agents probably were the most frequent, but they seem to have become far less frequent, and they're about 25% of cases. In terms of antibiotic anaphylaxis, so this occurs in 5 per 100,000 patients per year. So this isn't fantastically frequent, although the numbers are quite high and fairly shocking, but there's still 5 per 100,000 patients per year receiving at least one antibiotic perioperatively. If we translate this, because many patients receive more than one antibiotic, then this is about 4 per 100,000 antibiotic administrations. But there's a vast difference between the anaphylactic rate if you're receiving coamoxiclav or teicoplanin compared to if you administer metronidazole, for example. So, so out of the total cases, coamoxiclav caused 17% and teicoplanin nearly 14% of the 35%. And this was 89% of all cases of antibiotic anaphylaxis. If we say that if we use cefuroxime as a standard, so if we compare all the other antibiotics to cefuroxime and say that cefuroxime is 1 per 100,000 administrations approximately, then teicoplanin is 16-fold higher than cefuroxime, and coamoxiclav nearly 9 times higher than cefuroxime. And if you look at the third and the fourth most common antibiotics, these were vancomycin and tazocin, but they really were a distant fourth in terms of anaphylactic reactions per administration. So we've already heard that the most common presenting clinical feature was hypotension, and this occurred in 42% of all antibiotic cases. Second was bronchospasm, but that really was much lower down, at 15%. And the presentation of hypotension mainly occurred within 5 minutes in 76% of cases, and within 10 minutes in 92% of cases. So the vast majority of cases of anaphylaxis started with their first clinical feature within 10 minutes. The other thing that's really fascinating with this, because we've already alluded to the fact that there's a lot of mislabeling of penicillin allergy. There were about 50 cases of preoperative penicillin allergy labels, and 2/5 of them, 20 of them, and so this is 20 out of the 36 cases of teicoplanin allergy, actually had a preoperative label of penicillin allergy. And half of them had a grade 4 or a grade 5 reaction. And then the bottom two lines are about the investigation of allergy clinics, and they did not identify the antibiotic culprits in a quarter of cases because of incomplete investigation. So a typical history was that a patient presented with anaphylaxis, and the anaphylaxis occurred sometime into the anesthesia, so the patient would have induction with neuromuscular blocking agents, and then 10 to 15 minutes later they would receive an antibiotic, after which the anaphylaxis occurred immediately. But when they went to the allergy clinic, they were only investigated for neuromuscular blocking agents, and it was assumed that they were allergic to the antibiotic without any investigation. And the other thing that we found was that there were a lot of negative skin tests with a suggestive clinical history where patients were not being given drug provocation testing in order to either exclude or confirm the allergy. And in 2/3 of cases, inappropriate advice on future avoidance of antibiotics occurred. And this would, this could be because they didn't investigate the cases properly, or they were told to avoid too many drugs. So if there were two drugs, gentamicin and ticaplanin were a typical combination, they were told to avoid both, or they were not told which were safe drugs to have in case of future requirements. So there may be a risk of underdiagnosis of antibiotic allergy and inappropriate advice. So just very briefly, some of the data. So this is, there were 73 cases of antibiotic allergy labels preoperatively, about 50 cases of penicillin allergy. And as I say, 20 of these went on and developed anaphylaxis to ticaplanin. So this brings into question as to whether they were given ticaplanin because of their pre-existing history of penicillin allergy. If we look at the demographics, you can see 57% female for antibiotic allergy. And this is such a nice diagram which demonstrates that only 1% were under the age of 16, and then we gradually increase to 4%, 7%, 9% as we go up to 25, 35, 45, and there's a gradual increase in the percentage of anaphylaxis due to antibiotics with increasing age. In terms of culprits, you can see the two big culprits are coamoxiclav, which were 46 cases, or 49% of the total antibiotic load, and 36 or 39% ticaplanin. And when we look at the other cases, so there were 4 for cefuroxime, and there were 3 for gentamicin, but all the others were just 1 or 2. But that's also reflective of how commonly some of these antibiotics were administered. In terms of time interval, I've already mentioned that within 10 minutes, 92% of cases presented within 10 minutes, 73% within 5 minutes, and everybody presented within 30 minutes. But it would be unusual to find such a delay with antibiotic anaphylaxis. First clinical feature, again, 43%, hypotension, 15% with bronchospasm, 13% cardiac arrest. So the majority were cardiac related at first presentation. Clinical features at any time, again, almost everybody developed hypotension. You can see that here. But the other big ones were flushing and non-urticarial rash. Many of the cutaneous features occurred after resuscitation and after the blood pressure was restored, but also tachycardia and bronchospasm. And this is a really complicated diagram that I'm not going to go into. Grade of anaphylaxis. So if we look at the grade 5, so these are the deaths, and the deaths occurred only with coamoxiclav and ticaplanin. There were no deaths over the whole year with all of these other antibiotics. And in a way, that's quite reassuring, but also these were very small numbers. About 50% were in each of grade 3 and grade 4 for both coamoxiclav and for ticaplanin. There were 94 cases in total, 94 antibiotics implicated in total, but 92 were due to 92 patients, because 2 of them had gentamicin and ticaplanin equally implicated. So there were 92 patients, 94 antibiotics. In terms of allergy clinical diagnosis of the 92 cases, the allergy clinics considered 69 cases, of which 50 were definite to have been caused by an antibiotic. And so these are the definites, 50 here, and an additional 19 which were intermediate probability. In 12 cases, the review panel considered that an oral challenge had been omitted by the allergy clinic, so they could have undertaken an oral challenge to either confirm or exclude antibiotic allergy. And in another 11 cases, there was a possibility of undertaking an IV drug challenge to an antibiotic. So gentamicin and ticaplanin were the 2 that were implicated here. In 66% or 2/3 of cases of antibiotic allergy, which were identified by the review panel, it was felt that appropriate advice on future avoidance. And I just want to have a bit of caution here because this is based on the letters that were going back to the anaesthetist, so I suspect that this may be slightly higher than it should have been, but they felt that either that avoidance advice was not provided by the allergy clinic, either because of incomplete investigation of all of the culprits, or no culprit was identified, or no safe alternatives were clearly stated. The other problem, and I think this is a very important issue, that there was often excessive avoidance advice based on multiple antibiotics because of incomplete investigations. And in terms of, okay, this is a very busy slide. I think you've seen some of this data before. I have highlighted coamoxiclav and teicoplanin. These are, this is the annual caseload, estimated caseload per year. So 500,000 were receiving coamoxiclav each year, and about 220,000 teicoplanin. And these represented the vast majority of the cases of antibiotic allergy, so 17% and 13%. You can see the others are very small numbers. But if we look over here, gentamicin, 616,000. So in terms of administrations, we're giving a lot more gentamicin than we are giving coamoxiclav, but the numbers of cases of anaphylaxis are actually very, very low. So only 3 cases. So this is the cases per 100,000 administrations, so 0.5 per 100,000 administrations. So the only other 2 that really exceeded 1 were tazocin, which was 3.5, and vancomycin, about 6. All the others were very low numbers indeed, compared to, and we've used cefuroxime as 1, and you can see the numbers much more clearly here. So these are the big 4. So I'm just going to reiterate this. So teicoplanin, coamoxiclav, vancomycin, and tazocin in that order. Anaphylaxis with the other antibiotics was actually pretty uncommon. In terms of recommendations, so we really do need to focus on the recommendations that NAP6 have promoted, and the recommendations for antibiotics. If we look at this one, I think this is a very important one. 90% of anaphylaxis due to antibiotics presents within 10 minutes, more than 90%. So when perioperative antibiotics are indicated, they should be administered as early as possible, and where practical, at least 5 to 10 minutes before induction of anesthesia. Now, Tim's put this bit in here, but anyway, I think 5 to 10 minutes before induction of anesthesia. The anaesthetist should consider coamoxiclav and or teicoplanin amongst the likely culprits. And prior to NAP6, I think penicillins and coamoxiclav particularly were considered likely culprits. But now I think we really do need to think about teicoplanin. I suspect that if we'd done this 5 years ago, teicoplanin use wasn't particularly high on the anaesthetist agenda, but now we're using it increasingly, and I suspect its use will continue to increase unless people take note of the problems with mislabeling, etc. Avoid test doses of antibiotics. We haven't really spoken very much about test doses, but that certainly was one of the recommendations. In terms of institutional recommendations, patients with a reported allergy to beta-lactam antibiotics and one other class of antibiotic should be considered for allergy testing. But this would increase the number of patients referred from, just from the data that we have seen here, by about 10,000 extra referrals to allergy clinics. And I think that would be almost impossible for us to deal with. So I think we've still got to be pretty selective in who we refer. In terms of allergy clinics, if you have a negative skin test, consider a challenge, and broad antibiotic and beta-lactam advice should be avoided. So I think I've just finished 1 minute early, so I'm going to leave you with some of the key findings, and we'll have questions at the end. Is that right? Yeah. Thank you.
Thank you very much. Excellent. Thank you very much. So we started 5 minutes late, so if everybody's a minute quicker, we'll be back on time.